Hello, this is Gina Piscatelli with a lecture for A&P 2 on cardiac output. So in this lecture, we're going to be looking at heart function, and it's an important concept because it assesses how efficiently the heart is distributing blood to body tissues, including the lungs. Now, cardiac output is defined as the volume of blood ejected by just one ventricle in 1 minute. And this typical value that's listed of 5 liters per minute is a value measured for the average man, average weight. It doesn't reflect every single body type, but it's pretty average. And if you recall, we have approximately 5 liters of blood in total. So that's pretty interesting that the ventricle pumps all of our blood in 1 minute. Yeah, that's what it does. So cardiac output, of course, can vary. For example, it needs to increase during exercise when the tissues are rapidly using oxygen and producing carbon dioxide, and the blood needs to transport those. And maximum cardiac output can be up to 4 to 5 times during exercise compared to cardiac output at rest. And in trained athletes, highly trained athletes, it might even increase up to 7 times a normal cardiac output at rest for them. So the difference between maximum cardiac output that can be produced by a heart in one person's body and the cardiac output that they produce at rest is known as cardiac reserve. And that cardiac reserve, of course, will be much higher in these highly trained athletes or anybody that regularly exercises, particularly with endurance training. Okay, let's talk about measuring cardiac output. And remember that cardiac output is the volume of blood ejected in 1 minute by just one ventricle. In order to measure it, we need to know how fast the heart is beating, how many beats occur per minute, and how much blood is ejected each time the heart contracts. That's called stroke volume. So stroke volume is the amount of blood that's ejected in one contraction, and that's just one ventricle. So if we use the typical values that you can see on this slide, for heart rate, the typical value of 75 beats per minute, and stroke volume, a typical value is 70 milliliters per beat. We just multiply them. And so 75 times 70 is 5,250. And of course the units would be mils per minute, volume of blood per minute. That's about the total volume of blood in a body. So in summary, this equation used to calculate cardiac output is cardiac output equals heart rate times stroke volume. And sometimes we even abbreviate it. CO equals HR times SV. So you know, it's an easier way to remember it, maybe. Okay, let's talk about stroke volume a little bit. First of all, stroke volume is not exactly the same with every single contraction of a ventricle. There's a little bit of variation from one beat to the next. Okay. Secondly, the stroke volume will depend on how much blood is present in the ventricle right before it contracts. This is known as end diastolic volume. And of course, once atrial systole is complete, now we have the maximum amount of blood in the ventricle. But this is diastole for the ventricle, right? So the ventricle's been at rest. So the end diastolic volume is the amount of blood present in the ventricle, the maximum amount, right before it's ready to contract. Also, I should say that sometimes, the ventricle contracts, but sometimes not all of that blood is ejected. So the ventricle might still have some blood remaining within it after it goes through ventricular systole or contraction. And this volume of blood left in the ventricle after contraction is known as end systolic volume. So we can actually calculate stroke volume if we know the end diastolic volume and the end systolic volume in this one ventricle. And then we can calculate the stroke volume. So notice in the picture, this picture on the left reflects the volumes in this graph here. So we're dealing with one ventricle, and at the end of diastole, it has 130 milliliters. So that's its end diastolic volume. This is the amount available in the ventricle to be ejected. But after it contracts, at the end of systole, there's still 60 milliliters of blood remaining in the ventricle. So this is called the end systolic volume, end systolic volume, or ESF. Therefore, the stroke volume was 70 milliliters. You just take what was available, 130, and what remained, which was 60, and your answer is 70. Whoops, did I do that right? I think so. 70 mils. Okay, so now we've learned concerning cardiac output and assessing heart function, we've learned two main equations that you should remember. The first is cardiac output depends on heart rate and stroke volume. And so cardiac output equals heart rate times stroke volume. Secondly, we've learned that stroke volume is equal to end diastolic volume minus end systolic volume. So I recommend that you remember these two equations for both lab and lecture. Now, at the onset of this lecture, I mentioned that cardiac output varies minute to minute or hour to hour depending on your activity level. So now that we have these equations in our head, you might be able to understand what makes cardiac output change. If heart rate changes, cardiac output's going to change. If stroke volume changes, cardiac output's going to change. If end diastolic volume changes, that's going to change stroke volume, etc. Of course, the health of the heart muscle tissue will also change stroke volume. But we're just going to look at some really simple examples here. Okay, so if heart rate increases, you should get an increase in cardiac output. This happens with exercise, for example. If stroke volume increases, you should also get a higher cardiac output. And remember, I talked about endurance athletes having a higher cardiac output. This could be due to the health of their blood vessels, but let's just stick with the heart muscle for now. The myocardium might be able to increase its contraction efficiency, and so you have a higher stroke volume and you'll have higher cardiac output. But besides, the changes dealing with exercise, it's also often the case, at least at rest, that we wish to maintain a relatively stable and consistent cardiac output. And this is achieved in a couple of ways. So, for example, if your heart rate increases, but your stroke volume goes down, then you will maintain cardiac output at the same level. That's harder to think of. An example for that is harder to think of than the reverse, which occurs when we sleep, for example. So when we sleep, our heart rate goes down. But if our stroke volume goes up, then we're going to have the same cardiac output. Now, of course, when we're in deep sleep, we really don't need cardiac output to be as high as when we're out, being active. But this is a way that we can maintain cardiac output even when our heart rate goes down. So to talk about how to change the efficiency of heart contraction or stroke volume, let's look at stroke volume and how it changes in a little bit more depth. One of the main factors that control stroke volume of a ventricle, or the force of its ventricular contraction, has to do with how much a ventricle is filled before it contracts. So when a ventricle, I know this has both ventricles filled, but when a ventricle is not very full, it will contract with less force. This is because the muscle tissue isn't stretched. If it's more full, then it's stretched more, the ventricle stretched more, and it will contract more. It'll have more contractile force. So the stroke volume will go up in the case of more ventricular filling. So it turns out that a ventricle tends to eject the amount of blood that it receives during diastole. The higher the end diastolic volume, the more forceful the ventricle will contract. And this relationship between end diastolic volume, or how much blood is available in the ventricle, the relationship of that to stroke volume, was first described by two scientists. Their pictures are over there, Ernest Starling and Otto Frank. And so we refer to this relationship as the Frank-Starling law of the heart, which basically says that the more you fill a ventricle and the more it's stretched, the more forceful it will contract. So we know that ventricular filling impacts stroke volume. And in the clinical world, we refer to this ventricular filling as preloading the ventricle, or preload, right? So how can preload change, or how can ventricular filling change? Well, there's two main ways. One relates to the amount of blood that is returning to the heart from the circulation, the venous return. And the second relates to how long diastole lasts, or how much time there is to fill the ventricles. So the length of diastole. If we just look at the two examples of venous return here, like when we exercise, that increases venous return. That's because blood is flowing rapidly. We have a high heart rate too. But our skeletal muscles are pumping, are contracting and pushing against the veins, really pumping the blood back to the heart pretty quickly. So that increases venous return, and that will increase preload, and so stroke volume will go up. On the flip side, when we are sedentary or inactive, our venous return decreases. Our skeletal muscles are not pushing against the veins, and blood returns to the heart more slowly. And so that will decrease preload, or ventricular filling, and therefore also decrease stroke volume. But the concept of the fact that venous return impacts preload is what's central here. Okay, now let's examine how heart rate can affect preload. And this is a little bit tricky, and we're going to address it in lab. But let's just say, in general, if you increase your heart rate, you know you're going to get a cardiac output, a higher cardiac output. And if you increase heart rate, it shouldn't really affect stroke volume. But let's just say that we have, it sort of does though. Let's just say we have a low heart rate, okay? Well, that increases the length of diastole, but not too low, right? You don't want it too low because then you're not getting the venous return. But low heart rate increases how long the ventricle has for filling, and so you're going to basically increase preload. And a fast heart rate, although it increases cardiac output because your heart's just beating faster, if it's beating too fast, it decreases the length of time that the ventricle can fill. So that will lower preload, right? So your stroke volume will go down. We're going to play with these ideas of heart rate, stroke volume, and cardiac output in lab, so it should help you. So far we've discussed cardiac output and its relationship to heart rate, stroke volume, and preload in terms of just one ventricle. Now let's look at what's happening on both sides of the heart, left and right, in terms of cardiac output. In a healthy heart, cardiac output is the same on both sides. That is, the left ventricle ejects the same amount of blood per minute as the right ventricle. But what would happen if the stroke volume was different between the two ventricles? Well, then cardiac output isn't going to be the same anymore, right? Because the heart rate is the same for both sides. You never vary heart rate left to right because of the intrinsic conduction system. But stroke volume could vary, and that would be due to certain conditions known as congestive heart failure. Now, that's more of a symptom sort of diagnosis here, congestive heart failure. Congestive refers to swelling, and heart failure refers to, a problem in the heart tissue. But there's different causes, and these primary causes could be hypertension or high blood pressure in one vessel, a vessel on the right side or the left side, or a valve disorder on the right side or the left side, or maybe tissue necrosis, death from a myocardial infarction on just one side. There's various reasons that we get congestive heart failure, but in all cases, stroke volume will vary between the right and the left. One ventricle has a higher stroke volume than the other ventricle because the muscle tissue isn't equal, or the vessels that are receiving the blood aren't equal for some reason. Therefore, cardiac output is not equal on the left and the right side. And we refer to this type of heart failure as congestive because what we see is that we either get swelling in lung tissue, which is called pulmonary edema, or we get swelling in the body tissues, which is called systemic edema. And we get one or the other based on which side of the heart has been damaged. So let's look at left-sided first. So when the left ventricle has a lower stroke volume than the right, that means the right ventricle is going to eject more blood than the left. So we've got death and destruction on the left side. blood flows freely on the right side. Okay? What that means is that blood is going to be left or remaining in the left ventricle after it contracts, after systole. But the right ventricle has ejected blood into the pulmonary circuit normally. So we've got blood that goes into the pulmonary circuit normally. But it has a hard time re-entering the left side of the heart because the left side's got too much end systolic volume, which could creep up to the atrium. What results then is blood pooling in the pulmonary capillaries, and fluid or plasma escapes from these capillaries into the lung tissue, and that causes breathing difficulties. Okay, now let's look at what happens when the right ventricle has a lower stroke volume than the left. In this case, the left ventricle pumps a normal amount of blood out the aorta and to the systemic tissues. And the right ventricle doesn't send as much blood to the pulmonary circuit. And this right side, since it has this lower stroke volume, some of the blood remains after systole in the right ventricle. So blood returning from the systemic tissues gets backed up. It might make it up here to the vena cava, but nonetheless, it gets backed up or becomes more difficult to fill that right ventricle. And so what we get is blood pooling in the systemic capillaries, and fluid escapes those capillaries and goes into the tissues. This result is known as systemic edema. So we see swelling or edema in the systemic tissues with right-sided heart failure, which you can see in this slide here. Right-sided heart failure, you get backfilling on the right side, so you get systemic edema. But we see edema in the pulmonary tissues, in the lungs, with left-sided heart failure. So this ends our cardiac output, and we'll talk about its regulation in the next lecture. Thank you.